Welcome to the National Fellows Online Education Series, sponsored by AMSSM Fellows Education Subcommittee, the Education Committee, and the Fellowship Committee. Today, it says orthobiologics. I didn't change it, but it's actually non-operative management of osteoarthritis. And we have the great honor of having Dr. James Moeller speak today. And actually, fun fact, he was the inaugural chair of the Fellows Online Education Series when it began. So, and it really hasn't changed much because he did such a great job setting it up back in the day. Next week, we have early sports specialization in the pediatric athlete with Dr. Neeru Jayanthi. And this is to serve as an adjunct to your individual program's educational programming. It is to provide fellows with direct access to educational experiences with experienced AMSSM members and at times invited guest experts in a variety of formats. This should assist in CAQ exam preparation. Please mute your device, microphone, and turn off your video. Submit questions through the chat function. Include your name and program if you wish. The moderator will ask the questions during Q&A based on the questions you submit. After the program, please complete the evaluation, which will be sent at the end of the lecture. Dr. James Moeller, he did medical school at the Michigan State University College of Human Medicine, residency in family medicine at St. Joseph's, and fellowship at Michigan State University. He currently works at Henry Ford Medical Center. He is the director of Sports Medicine Fellowship, and breaking news, he actually will be leaving Detroit and joining West Virginia University Department of Orthopedics in January of 2024. And it sounds like he's not even going to give himself a week or two break. He is going to start right away beginning January 2nd. He served on the AMSSM Board of Directors 2005 to 2009, the chair of the Education Committee 2005 to 07, and then the chair of the International Interorganizational Relations Committee 2007 to 2009, which is pretty cool because now that's actually the committee that I am serving on, and it has built its iteration based on his recommendations. So it has been a really great way to build AMSSM's how people know about AMSSM throughout the other organizations that are complementary. And as I mentioned previously, he was the inaugural chair of the Fellows Online Lecture Series. Fun fact, Jim and his wife Marlo actually they raise leader dogs. And Jim, I'm going to have to ask you to explain a little bit more about this because it's really, really cool and I won't give it justice. But essentially, it sounds like you break your heart every year. So they come, you take a puppy and then you grade it, you make it kind of the best dog ever, and then you give it back to the organization so that it can help be a leader for the blind, I believe. So please tell us more about this. This is their most recent one. I'm going to stop sharing so Jim can do his. Oh, I'm Melody Hrubes. It's my honor to be the moderator. I'm at Rothman Orthopedics in New York, and that's really all I have to say about me because I'm not as cool as Jim.
Well, as I was actually telling her, she's cooler than I am. At least, my kids keep telling me that, which is great, for the ego when your children are telling you that there's another sports doc out there who's cooler than dad. But no, I appreciate it. Melody's one of my new favorite people. We actually met through virtual meetings over the course of a couple of years, and never met face to face until the last AMSSM. But then it felt like we were old friends, which was fantastic. And I'm really pleased to be here with her today, and excited that she's moderating. And I saw Siobhan on the group as well, and that's another person that same thing, the fantastic people. But I do appreciate everybody joining us tonight. So yeah, Leader Dogs for the Blind is something that my wife and I have done for the past several years, and it is breaking your heart. It's harder than taking your kid to college. My children are all grown and gone, but it's harder taking the dog back than taking the kids away to school. So what we do is when the dogs hit 2 months of age, Leader Dog, which is in Rochester, Michigan, and it's one of the largest breeding, raising, and training areas for guide dogs for the blind. They have volunteer raisers, and we take a puppy at 2 months, and we raise the puppy till about a year. and then we take them back and we give them back, and they get trained. They go to puppy college, basically to learn to be leader dogs and learn how to spot curbs and how to react to traffic, and how to basically take blind people through their lives in a more independent fashion. And in fact, our second dog had to actually learn sign language, because she also has a client who is blind and deaf. And so she had to go through what they call SEALs training for the dogs. But we've raised two that have passed, and one's leading a woman in Georgia, and our second one is leading a man in Utah. Our third one is back in college right now. Our youngest daughter, who's in graduate school at Georgia Southern, is raising her first puppy for the organization. Our third puppy is back in their training right now, and we're picking up our fourth in a week. So that's what we do, and it's really hard, but it gives people a better life, and hopefully. And if the dog doesn't make it through the process, and about 2/3 of them don't, fortunately for people, ours have made it, but unfortunately for us, they've made it because we get first dibs on getting the dog back. So we're hoping someday we get a dog out of it. But anyway, that's that. So, but thank you for mentioning that. It's something that's near and dear to our hearts. So I'm hoping everybody can see my screen. DJ, did I do it right? Because my tech fellow from last year is on.
It all looks good.
Perfect. All right. So non-operative management of knee osteoarthritis. And as Melody said, I'm the director of the Sports Medicine Fellowship at the current time at Henry Ford Health in Detroit, Michigan, which will be changing soon. This is a really important topic, and there's debate. Is this sports medicine? Isn't this sports medicine? Here's the truth about things in the country at this point. Orthopedic surgeons are very highly specialized. And so the joint replacement surgeons, they really don't want to see patients with arthritis unless they need joint replacements. And in primary care training, and I'm family medicine trained, so I think I can say this with good honesty, the training in musculoskeletal medicine still isn't where it needs to be, where people are comfortable in taking care of common musculoskeletal problems on a regular basis. And because of that, musculoskeletal experts, like sports medicine trained physicians, become the go-to when it comes to these very common musculoskeletal problems. And if you know how to take care of osteoarthritis, especially of the knee and hip, and like to do that and are willing to do that, you'll never have a problem having patients in your schedule, because it's just a very widespread problem. We'll talk about that. So let's get on with the talk. First of all, I have nothing to disclose regarding the content of tonight's lecture. And I want to just review for you what the goals and objectives for tonight are. We want to review the epidemiology of knee osteoarthritis, look at some of the pathophysiology and clinical presentation, get into diagnostic testing for a short period of time, and then look at the treatment options, which is really the focus of the talk. So to start, I just want to go with a question from a recent CAQ examination, and this is taken from the AMSSM Sports Medicine CAQ study guide. That came out recently. A 75-year-old male with controlled hypertension who enjoys golf and doubles pickleball, who uses lisinopril, complains of medial knee pain in the absence of trauma. His pain is associated with morning stiffness and has been present for the past few months. He does see some improvement with oral ibuprofen. Which of the following is appropriate in the overall management of osteoarthritis for this patient? So they're giving you the diagnosis. And the foils for possible responses included these: weight-bearing radiographic views may assist in determining loss of joint space. Anti-inflammatory medication is the first-class drug of choice for pain relief. Alternative medicine modalities have no role in pain relief for osteoarthritis. And arthroscopic debridement would be the most effective intervention at this time. And if you look at each of these foils, we'll start from the bottom and move up. Arthroscopic debridement at this point is not considered one of the treatments for osteoarthritis of the knee, certainly not something that we should be using on a regular basis. In fact, there's evidence against the use of arthroscopic debridement for osteoarthritis. And we'll review all these things in the course of the talk. Alternative medicine modalities, they do have a role. There are a number of supplements which can provide some relief, even though they're maybe not first line. Anti-inflammatory medication is actually, there's strong evidence for the use of anti-inflammatory medication. However, this person is on lisinopril, and anti-inflammatories could reduce the effectiveness of that medication. And a medication like acetaminophen is generally safer and considered first line. And so the correct answer is that weight-bearing radiographic views may assist in determining loss of joint space. So with that, let's get on with things, and we'll go back to our goals and objectives. First thing is to look at epidemiology. Arthritis is the most common joint disorder in the United States, with a prevalence of almost 1 in 5 or 1 in 4, but that's all forms of arthritis. So it's osteoarthritis, rheumatoid arthritis, it's lupus arthritis, it's the seronegative small arthropathies, gout, pseudo-gout, and so on. It includes pediatric forms of arthritis as well. We do know that the incidence is increasing. This equates to about 32.5 million Americans with arthritis, with knee osteoarthritis, or I'm sorry, with osteoarthritis, not just knee, but knee is the most common area for osteoarthritis. So again, if you look at 50 million patients in the United States with all forms of arthritis, 32.5 million, this is based on 2020 CDC data, having osteoarthritis, and again, the largest number of those for a single joint being the knee. You can see why it's such a major problem and why we have to know so much about it and why it's so widely studied. Females, especially over the age of 65, are much more common to have knee osteoarthritis compared to males, almost at a 2-to-1 ratio. When you are under 45, actually males are more likely to have knee osteoarthritis than females. But again, as the population ages, more and more females develop this problem. It's estimated that 240 per 100,000 people per year will develop osteoarthritis to the point where it is diagnosed, because there are lots of people out there that have the changes if you were to just do blanket x-rays on everyone and look for change. But we don't know that they're having problems until they come to see us. And so again, it's hard to know what the actual incidence is. If you look at that CDC data from 2020, you can see that it's estimated that 50 plus million people in the United States have some form of arthritis. And again, this is all forms. If you consider osteoarthritis, again, it's around 32.5 million, as depicted by the blue diamond. And if you then look at the percentage that's knee osteoarthritis, it's probably around 14 million or so. And those numbers are only going to increase. Now, the incidence of certain types of arthritis really doesn't change over time. The number of people with gout, the number of people with pseudo-gout, the number of people with lupus, the number of people with rheumatoid, it's not going to change as much as the number of folks that have knee osteoarthritis. And over time, these numbers, again, are just going to increase. Part of the reason for that is that our population is aging. And as we'll see in a minute, age is a risk factor for developing osteoarthritis. And overweight is another risk factor for developing osteoarthritis. And we all know that there's no obesity epidemic in the country, and that's going to lead to more and more patients who develop osteoarthritis, especially of the knee and hip, over time. Now, this high number of folks that have this, it does have a great deal of implication with regards to costs, both direct medical costs and indirect medical costs. In 2013, it was estimated that over 300 billion, that's with a B, billion dollars in the United States was spent or lost because of osteoarthritis, and $140 billion was in direct medical cost, with 164 billion being in lost wages and lost work productivity. And so again, this is a major issue. It's expected that by the year 2030, the number of patients having total knee arthroplasties in the United States is going to reach 3.5 million per year, and that's very costly. Revision surgeries are also increasing. And so if we know that most of the direct and indirect cost of treatment is due to total knee arthroplasty, and TKA rate increases significantly overall, and costs will go up by the transitive property, A equals B and B equals C, then A equals C, the number of TKAs that go up, the number of the cost is going to go up. What's interesting is that the cost of care for knee osteoarthritis is directly linked to the patient's subjective report of pain from their osteoarthritis, and not as well linked to the degree of osteoarthritis at the time they present. In fact, here's a grid looking at patients who present with moderate pain. Those are the three graphs, three bars on the left, versus people who present with severe pain. Now, KL2, KL3, and KL4 is the Kellgren-Lawrence grade of osteoarthritis, and that's a grading system we'll go over in a few minutes. But you can see a person who has grade 4 changes, that's potentially bone-on-bone change, who comes in with a complaint of moderate pain, the total cost of care for them throughout the rest of their lifetime is going to be lower than someone who comes in with only a moderate amount of arthritis, but they're complaining of severe discomfort. So it's very interesting that the degree of arthritis on X-ray doesn't necessarily correlate to the degree of pain that the patient complains about or the potential cost of treatment over time. So it's something to remember as we move forward. Now, when you think about arthritis, you have to consider comorbidities. Remember, we said that the incidence of arthritis is, or the prevalence rather, is 23% in the United States. And that's, again, the adult population, all forms of arthritis. So when you look at these numbers here, what this is saying is that patients who are obese are 50% more likely to develop some form of arthritis than patients who are not obese. People with diabetes and heart disease are twice as likely to develop some form of arthritis. This is not just osteoarthritis. Now, if you take these comorbidities and turn them around a little bit and say, let's look at people who we know have osteoarthritis and look at what their comorbidities are, 90% of those people will be overweight or obese, 40% will have hypertension, 30% depression, and 15% will have diabetes mellitus. And so again, we have to look at the entire patient when we're doing treatment, because we can't just focus on the disease process like it's in a vacuum. We have to look at other things that may be affecting their overall health and putting them at greater risk. So what are the risk factors? We talked about older age being a risk factor, especially females as we get past the age of 65. Again, males under the age of 45 have a higher likelihood of developing osteoarthritis than females, but the females catch up and then surpass males as aging goes on. Being overweight, as we just mentioned. Prior joint trauma, which may lead to joint surgery. So perhaps an injury in youth that led to an ACL tear, meniscus tear, partial meniscectomy, ACL reconstruction, that can set the ball rolling for earlier onset arthritis. And a family history also plays a role. There are certain occupations that are considered to be higher risk, occupations that require a great deal of squatting or weight bearing on the knee itself, and high load or high impact load sport activities, but not all sport activities. And so we have to be careful in how we look at that. I'm showing obviously a weightlifter in this picture, but one of the things that you'll often be asked is, what about running, doc? I like to run. Is that gonna cause me to get arthritis? And running has often been associated with early onset or accelerated knee osteoarthritis, but this has not actually been shown to be the case. In fact, multiple studies have shown that runners and non-runners develop osteoarthritis with the same incidence over years. And so whether somebody runs or doesn't run is not likely to dictate whether they develop osteoarthritis or not. In fact, there was a meta-analysis that showed that patients who are runners will have a lower likelihood of ever needing knee surgery for osteoarthritis, which is an interesting finding. Now, what they're talking about is patients who basically start with clean knees, if you will. And so if you have no prior injuries, no other greater risk factors for developing osteoarthritis, the likelihood of running causing you to develop it is pretty low. And in fact, no different than somebody who's a non-runner. If you already have an arthritic knee and you are running on that arthritic knee, that could accelerate it slightly faster, but not necessarily to a great degree. I always tell my patients with knee osteoarthritis, and they say, can I keep running? I said, well, do you enjoy running? How much do you enjoy it? Because if you're going to run yourself into a joint replacement at 65 instead of 70, would that have been worth it to continue running for those next 10 years? And if they say yes, I said, well, then keep running till you need till you can't anymore. Because I don't want to take that positive benefit for health, the positive benefit for their mental well-being that they get from running, and take that away from them because they're on a path towards greater degeneration of the knee. Because once you're on the path of degeneration in the knee, you stay on that path. It's just a question of how fast you go down that path. So again, running does not cause arthritis. In fact, it can lead to a reduced need for joint replacement in the future. And so that's something that most people don't understand, is something you'll have to be able to explain, especially to your active individuals with osteoarthritis. And that a number of patients with that are going up. Pathophysiology. Remember, there's both primary and secondary osteoarthritis. Primary osteoarthritis is basically the wear and tear, the one that you get with aging. I joke with my patients that I hope I live long enough to get really bad knee osteoarthritis. It means usually for most people that they've been around for a while and they've done a lot of stuff. And I hope to be in that group someday, that I live long enough to get arthritis because I've been doing lots of things and I've lived a long time. There's a strong genetic component to primary osteoarthritis as well. Secondary osteoarthritis tends to occur at earlier ages and is either due to activity or injury, as I was mentioning before, just as an example, an ACL tear, meniscus tear that requires surgery, those kinds of things, or due to another condition. So for example, if somebody has a BMI of 50 and they have osteoarthritis, it's really secondary osteoarthritis, not primary. Now, if we look at the different tissues in the knee, the articular cartilage, meniscus, the synovium, the bone, all of these different areas are affected by arthritis. The ones that we can tell based on radiographs, which is how we primarily make the diagnosis or confirm the diagnosis, is probably more accurately stated, is because of joint space narrowing, which is due to articular cartilage thinning, and then bone spurring. So we're talking about articular cartilage change and bone change. But again, all of these tissues are affected. If we look at articular cartilage specifically, water content will increase, proteoglycan content will decrease, and that changes the network of the collagen and weakening of the collagen and thinning and splitting and fibrillation and things of that nature. And also binding of the proteoglycans to hyaluronic acid, which can reduce the effectiveness of the cushioning of the tissues in that area. So articular cartilage changes. If we think about meniscus cartilage, I like to think of it like mud on a riverbed because it loses water content. If you ever look at a riverbed when the sun is out and the water level is low, the mud will dry and eventually dry enough to the point where it cracks and splits. And meniscus cartilage can do the same thing. And so you lose the cellular organization, you get the drying and cracking and splitting of the degenerative tears that are commonly seen. In fact, at certain ages, it's more likely to find a degenerative tear if you look for one than to not find a degenerative tear. And we'll get into the question of whether or not MRI should be obtained in patients with osteoarthritis later. If we think about the synovium, the synovium in the capsule, there are some inflammatory components to the changes that take place, even though osteoarthritis is not technically an inflammatory type of arthritis. Eventually, what happens is the synovium thickens and starts to produce a synovial fluid, which provides less lubrication than it should. And again, that helps lead to some of the symptomatology that is seen. Finally, with the bone, you get subchondral remodeling, cyst formation, eventual osteophyte formation, which again is the finding on X-ray that you can point to quite easily when it's present. So moving on, the clinical presentation is typically going to be someone with atraumatic knee pain that worsens with use. They may or may not complain of swelling and crepitus. It tends to worsen later in the day. So the more they're on their legs, the worse it tends to get. Oftentimes first thing in the morning as they start to get going, they have a little bit of soreness, but it loosens up a little bit. But again, the longer they're on their feet, the worse things feel. They may complain that they have changes in the appearance of their knees, and they may also complain of functional issues and mechanical issues such as catching, locking, reduced range of motion, and difficulty with normal daily activities. Now here, obviously, this is I picked this picture on purpose to really overstate how the body can change in reaction to joint space narrowing with this person with significantly varus knees. Usually it's going to be a little more subtle, but still noticeable. On examination, they may have gait alterations or be using assistive devices. They may have visible deformities. You want to look for those things. You want to check their neurostatus and vascular status, but usually those are going to be intact. older people can have varicosities and other vascular issues that are going on that may or may not actually be playing a role with their knee pain. On examination, they'll often have tenderness to palpation and a feeling of bony enlargement in the knee, and the tenderness is generally in the joint line that's most affected. They may have an effusion. This is actually a 16-year-old patient of mine that I saw a couple of weeks ago. I had to get the picture because I didn't have a good, clear picture of someone with visible effusion. She has an idiopathic type of juvenile arthritis that's not been fully elucidated yet, but she came in with this large effusion, and I thought it was just a good depiction of what that looks like. But again, you want to check range of motion for signs and symptoms of issues such as decreased motion, painful motion. Can you sense crepitus as you're moving them through their range or while they're going through active range? Excuse me. Strength is usually maintained. Ligaments typically are stable. And cartilage provocation test, this is an interesting one because the provocation test will often be positive because you're putting pressure into a compartment of the joint that has degenerative change. And it could be meniscal, it could be articular cartilage, it could be both. There could be bony changes and rubbing bone on bone or rubbing a spur up against something. So there's a lot of reason why you could have positive provocation tests. Now, when I approach this from a clinical standpoint, I have a few different examinations that I like to potentially perform. I tend to rely mostly on the McMurray test, and a true McMurray test is positive if there's a clunk or a click in the joint line or locking of the knee during the course of the test. If it doesn't cause that but causes pain, I call that a positive flexion circumduction test. That's just me. If I can't flex the person to past 90 degrees, then I'll usually pull out the Apley's compression distraction test as my test of choice, because I like to flex them past 90 to get a true McMurray's. If I can't even bend them to 90, then the Thessalate test can be utilized, not named after a person, named after a region of Greece that looks lovely. And I think that we should probably have AMSSM there some year. Again, you need to have different examination options at your disposal so you can do an appropriate evaluation on a patient based on their abilities to tolerate different portions of the examination. But remember that even though they may not have a specific cartilage defect, like a tear in the meniscus per se, your meniscus test may be positive. Moving on to diagnostic testing. X-ray is the only diagnostic test needed to confirm the diagnosis of osteoarthritis. Advanced testing is really used to look for other things, occult fractures, bone tumors, things of that nature. Meniscus tears you can find obviously on MRIs as well. But to make the diagnosis of osteoarthritis, really a good X-ray series is what you need. And the X-ray series that I like is an AP standing view, a PA standing flexed view, a lateral view, and either a sunrise or a merchant view. So I do a 4-view series on patients over the age of 40 because I'm looking for arthritic change. And the PA standing flexed view is the view that's going to accentuate joint space narrowing the best in most cases. And what you see here on the left is a standing radiograph AP in full extension on your left-hand side, where you can see the sclerosis, you can see the squaring of the joint line, you can see a little luxation, but when you put them in the standing flex position and shoot it from a PA direction, as you see on the right, you can see a difference in the joint space on the medial side that you didn't pick up when they were in full extension. And so again, that PA standing flexion view is very, very important. Even when the person has obvious arthritis that's more advanced, like this patient, and these are patients from my clinic. This is the same patient. Again, the radiograph on the left is the AP full extension standing view, and then the examination on the right is the PA standing flex view. And so even though it looks like they have some space laterally, and a little bit of space left medially, when they get into that flexion view, you can see that it just closes right off. And occasionally you actually will find this really rare occurrence where somebody has autofusion of the knee. That's an N of 1 in my 30 years, by the way. So with a lot of things, when it comes to imaging, if you can see it, you can grade it. And right now, the Kellgren and Lawrence grading scale is what's most commonly used. And so this is the Kellgren and Lawrence scale. It's a little bit vague in my view, and leaves a little bit for interpretation from one individual to the next. But this is the system that we use most commonly. Grade 0 is not arthritis. There's no joint space narrowing. There's no osteophytes. It's a normal looking X-ray with regards, again, to the potential for osteoarthritis. Grade 1 change is doubtful narrowing, but possible lipping. So if you see some subtle changes, that may be the earliest sign of arthritic change, that's a grade 1. If you definitely see lipping or early osteophyte formation and maybe just a tiny hint of joint space narrowing, that's a grade 2. Grade 3, there's definitely some narrowing going on, but the osteophytes are getting bigger, and that's where you're going to see some sclerosis developing and some possible and bone end deformity. And then grade 4 is the marked change, where you're getting close to bone on bone, if not bone on bone, with large osteophytes. And so if you look at it, 1 is really kind of early, 2 is mild, 3 is moderate, and 4 is severe. That's just another way to potentially state it. And in our system, radiologists usually say mild, moderate, and severe. They don't actually state a Kellgren-Lawrence scale number, but we tend to use that when we're seeing patients in the clinic and when we're presenting, when fellows are presenting to me in their sports medicine clinics. Now, the American College of Rheumatology said, well, do we really need to get all these x-rays on people to determine whether or not they have arthritis? Shouldn't it be easy to tell clinically whether they have this or not? And so they came up with this plan in the mid-1980s to look at that, and said that if someone presents with knee pain and one of the and any 3 of these following things to go along with their pain, you can go ahead and make the diagnosis of knee osteoarthritis without obtaining radiographs. Somebody over the age of 50, morning stiffness less than 30 minutes, because if it's over 30 minutes, you're thinking more potentially of some type of rheumatologic disorder, rheumatoid arthritis or something of that nature. They have crepitus on active motion, bony tenderness, bony enlargement, and no palpable warmth of the synovium. Again, any 3 of those with knee pain, go ahead and make the diagnosis. But how accurate was that? Well, it wasn't very accurate. A study looking at using the ACR criteria and then actually looking at people and their x-rays showed that a group of 259 symptomatic patients had x-ray proven OA, while 529 symptomatic patients were x-ray negative. And so the ACR criteria for OA only showed a sensitivity of 41%, a specificity of 75%, and a positive predictive value of 44%. So again, good history, good examination, appropriate x-ray series, and you can make your diagnosis. And then this just highlights the overall numbers there that came up with the sensitivity and specificity I just described. But what about MRI as a test? We get a lot of patients that are sent to us, their MRIs are already performed. This was a study done out of the University of Utah. I had 100 patients, which is great for math for me. It makes it easy to figure out percentages. But what they did was they looked at patients who were seen by their primary care providers for knee pain and tried to determine, were MRIs appropriate or not appropriate. And over the age of 40, only a small percentage of people actually had x-rays performed before they had an MRI. They went straight to MRI. Less than half had x-rays. And only 7 of the 100 patients had a standing flexion x-ray done. And we've already discussed how that's going to be your most helpful view to try to determine what the true joint space narrowing is. The interesting thing is that the only treatment that changed drastically because of the MRI was the number of patients that were sent to an orthopedic specialist for follow-up. And you can see at the bottom there were 9 were already arranged to go to see somebody, either a sports medicine physician or an orthopedic surgeon, because in that group both were present. After the MRI, 76 of those patients were actually sent later. So that's the only thing that changed in my eyes. Just send them to the orthopedic specialist, sports medicine physician for the evaluation instead of getting an MRI that's not going to be potentially useful. And when they asked the orthopedic specialists, and again, this included primary care trained and surgical trained people, only in 12 cases of the 100 did they agree that an MRI was actually necessary? And none of them were in anybody over the age of 60. So let's get to the meat of what we want to talk about tonight, and that's treatment options. So it took a long time to get here. I apologize for that, but I thought it was important to go through the background as to why we get to treatment, the treatment options we're going to talk about. So we're going to divide this up into two things. First is very quick, and what are the goals of treatment? And then we'll get into the actual options themselves. And the goals are pretty simple. You want to bring their pain down, bring their function up, and keep them from needing surgery. And that's really the gist of it. And that's our goal, that's our job. Help keep them functional, help keep them in a happy place with regards to their discomfort, and try to keep them away from knives. I look at arthritis treatment like a train going down a track. If you're on the path of arthritis, we're not going to go backwards along that path. We're going to go forwards. The question is, how fast do we go forward, and how much does it bother us while we're moving in that direction? Now, what you don't see on this is a parallel track that's your life track. So if this track for arthritis treatment, and we'll go through the different treatments, if the end of that track is joint replacement, on your parallel life track, the end of that track is death. And so you're moving down both of these tracks at the same time. And I don't want to be morbid or anything like that, but when my father was alive, he had really, really bad hip arthritis. And he kept asking me, Jim, when do I get my hip replaced? When do I get my hip replaced? And I said, I don't know, Dad, when do you? Because it's always your choice. The patient decides when this is. And I said, Dad, I can promise you it's going to end one of two ways. You're going to die before you get your hip replaced, or you're going to get your hip replaced before you die. And he ended up dying before he got his hip replaced. It never got bad enough for him to decide it was time to go ahead and get it replaced. But again, you're on this track, you're on this train moving in one direction. And what we want to do is keep people from getting to the end stop, which is joint replacement, if we can. But remember, joint replacement is a good surgery, and it helps a lot of people. And if they have to get to that spot, it's someplace that we have to help them get to appropriately, so they can go through the surgery, have a good recovery, and then enjoy the surgery afterwards as well. But when we look at the non-surgical treatments, you can divide it up into 4 different categories: truly conservative management, pharmacological management, procedural, which is kind of a mix between procedure and pharmacologic, because conservative things are things like physical therapy. Pharmacologic obviously would be things like medications, oral, topical, and even supplements. Procedural would be things like injections, but again, that usually comes with medication as well. We're not doing saline injections for most people. Acupuncture would fall into that category as well. And then there are surgical options that are not arthroplasty. So things like high tibial osteotomy, again, arthroscopic lavage, meniscectomy, things of that nature. What I would suggest is that you all go and try to look this up. The American Academy of Orthopedic Surgeons did a review that was published in 2021. And this was a revamp of something that they did in 2013, looking at the management of osteoarthritis of the knee that did not include arthroplasty. And this particular set of guidelines, they went over nearly 600 different studies, mostly randomized controlled trials, to come up with recommendations on how non-operative, non-arthroplasty treatment should go. And they came up with 27 different forms of treatment, and then graded them based on whether there was strong, moderate, or limited evidence for the use of that treatment, or strong, limited, or moderate evidence against the use of that treatment. And we'll talk about those things right now. So there's strong evidence for the use of topical anti-inflammatory medications, oral anti-inflammatory medications if the patient does not have another contraindication for their use, oral acetaminophen, exercise, and self-management and patient education. So helping the patient understand their disease process, helping them understand ways that they can help manage their own care, and that it could include home program of exercise as well. All of these things have strong evidence for their use. So exercise is certainly favored over no exercise at all, but the amount of exercise doesn't seem to be as important as some exercise. Whether it's supervised or unsupervised doesn't seem to matter so much. Whether it's land-based or water-based doesn't seem to matter quite as much unless it's a comfort issue for patients. And a lot of patients doing water-based exercise is more comfortable because it unloads the joint more. But again, these things have strong evidence for their use in treatment of knee osteoarthritis. When you look at things that have moderate evidence for use, it would include things like canes, braces, neuromuscular training, weight loss. All of these things can fall into the conservative category that we talked about before. Intra-articular corticosteroid injection, which is a procedure / medication, pharmacologic there. And partial meniscectomy has actually still been shown to be helpful, but you have to pick the right person. You don't just do partial meniscectomies because they have degenerative meniscus tears, because most people will have a degenerative meniscus tear. It needs to be a meniscus tear that's actually probably affecting the function of the knee in a significant manner. Because if you go in and remove some of that meniscus, you've created trauma to the joint, less cushioning to the joint. You're going to accelerate their arthritic process and take them down a path potentially to arthroplasty faster than if you leave the meniscus in place. Now, this particular set of guidelines did not mention the use of injectable non-steroidals, which may have less chondrotoxic effect than a corticosteroid. And so it'll be interesting to see if that comes up in the next group. We know that injections of medications like ketorolac does lead to significant pain reduction, just as a corticosteroid does. And usually for about the same amount of time. But again, it was not part of this set of guidelines. When you compare the 2021 guidelines to their 2023, these areas here all showed a, they were all basically downgraded from prior, from the prior set of guidelines. So before, braces, neuromuscular training, weight loss, and intra-articular corticosteroid injection all had strong evidence for in 2013, and they only have moderate evidence for in 2021. Limited evidence was found for the use of supplements, including things like turmeric, ginger extract, glucosamine, chondroitin, vitamin D, manual therapy and massage, laser therapy, the use of electrical treatment like TENS units and E-stim, acupuncture, and this is an image of someone who had acupuncture done and needles were broken off. You don't want to use an acupuncturist that leaves a patient looking like this. Shockwave therapy, platelet-rich plasma, denervation treatments, and that would include geniculate nerve block, and if that nerve block is successful, potential radiofrequency ablation, and high tibial osteotomy. Again, we're talking about non-arthroplasty treatments, not necessarily all non-surgical treatments when we're looking at this list. But these were the things that showed limited evidence for. And when you look at this compared to the 2013 list, all of these were downgraded from moderate to limited evidence. What we're finding is that the more we study osteoarthritis and we are looking at specific types of treatments for osteoarthritis, we're finding that a lot of the things that we do probably don't work as well as we thought they did. It doesn't mean we can't use them. It just means that we need to be educated and be able to educate our patients appropriately on what we recommend based on evidence. Because if we're going to practice evidence-based medicine, we have to understand what the evidence shows. If we move on to things that are not recommended or there's evidence against, there's moderate evidence against the use of hyaluronic acid injections, which most people find fairly shocking. We have studies, and you can tell me in the chat and ask questions about, well, I read this study that showed that hyaluronic acid was effective in helping treat patients' pain and giving them better function. And I'll say, yes, I read those papers too. But if you read a large block of papers on the use of hyaluronic acid injections, you look at cost-benefit ratios and things of that nature, it doesn't really change much with regards to people still progress. People still go on to needing more advanced types of treatment. And so right now, based on the evidence, the AAOS has given hyaluronic acid moderate evidence against TAG, which is equal to arthroscopic lavage and debridement. And we know none of us would recommend arthroscopic lavage and debridement for our patients anymore. It's no better than a sham operation in helping people with their osteoarthritis pain. And that was proven many, many years ago. Yet we do recommend, and we all perform a lot of hyaluronic acid injections, even though it has the same recommendation based on current evidence. And so if you're going to use hyaluronic acid injections, and I do still, I'm not saying I don't use them, you want to pick the right patients again. We do know that patients with grade 1 change and grade 4 change really aren't great candidates for hyaluronic acid injections, because people with grade 1 change will probably do well with lower forms of treatment, less invasive forms of treatment, less expensive forms of treatment. People with grade 4 change are probably not going to get any significant benefit. You know, when I get a little, I've been around for a long time. You know, when Melody introduced me, you know, part of the slide said experienced AMSSM members. That means old in my case. And I get a little bit, I don't want to say miffed, but when I have to call and explain why I want to get an MRI on a patient, I get a little testy. And because I'm not ordering lots of MRIs, and I think I'm ordering one because I need the information to make a good clinical decision with regards to how I'm going to treat my patient. I hate to have to explain that to people, but I do, and I get on the phone and I try to be real nice about it. But I never have to explain to anybody why I want to do a hyaluronic acid injection on someone who's bone-on-bone arthritis, where I know it's highly unlikely that it's going to have any significant effect, certainly not last 6 months. But again, it's something that carries right now a moderate evidence against moniker. And when you look at this compared to 2013, again, this was a downgrade, because in that decade in between, more and more studies came out that basically showed that it's not as helpful as we once thought it was. And things that carry strong evidence against use include lateral wedge insoles, narcotics, and tramadol, as you're well aware. So if we look at these things in a slightly different way, when we consider just the conservative managements of that list that we just reviewed, there's strong evidence for the use of some form of exercise with self-management and patient education. So those things we should be using all the time. Pardon me. There's moderate evidence for the use of canes, braces, neuromuscular training, which can be part of the exercise program, and weight loss in people who are obese. Again, those are things that we should be recommending in the appropriate patients, or at least offering. And then there's limited evidence for the use of laser TENS, stim, manual therapy, and massage, which would be done in physical therapy, which would be potentially part of one of the stronger evidenced forms of treatment. And in conservative management, we know that there's strong evidence against lateral wedge insoles. So again, think of using the things on the left side of this screen, and think of avoiding the things on the right side of the screen. If we look at pharmacologic agents, again, strong evidence for the things on the left side, which is basically going to be your NSAIDs, both topical and oral acetaminophen. And again, selecting the right patient based on other types of medical issues. Do they have chronic kidney disease? Do they have a problem with ulcers? Are they on blood thinners? Things of that nature where you may need to avoid NSAIDs. Those have to come into consideration in your decision making. And then supplements, there is some good evidence that it can be of some benefit. So there are a variety of, like we said, of supplements: turmeric, ginger extract, glucosamine, chondroitin, vitamin D, that may be of some benefit and probably little harm. Again, strong evidence, you want to avoid the things on the right-hand side of the screen, the narcotics and the tramadol. When we're talking about procedural treatments, corticosteroid injection, I would like to, from my reading, I would add intra-articular NSAID injection as well into this category. Into the left-hand side, I don't know which category would fit. I've not done enough reading on that area to be able to tell whether it would be strong, moderate, or limited. But the things like shockwave therapy, PRP, denervation procedures, all these things are possible. And to me, those are things you're getting into as you get closer to, as you're going further down the track. Don't necessarily start with those things, but you may add them in later on to, again, try to avoid surgery if necessary. Right-hand side of the screen, those are things we should consider to maybe avoid. And again, this is controversial because we all use hyaluronic acid injections. It's funny that the things that are on the left side of the screen, a lot of them don't get paid for by insurance companies, but they'll pay for things where the evidence is not so strong. And as I told you, I do use hyaluronic acid to a fairly large degree, but I try to make sure that my patients are educated on what we're really expecting from it. And that's limited pain relief and basically trying to keep their function level up, their pain level down, and try to delay the need for surgery. And finally, the surgical managements. Again, it's not the focus of this talk. Total knee arthroplasty is not in this group, but there are some surgeries that might be done to help out short of arthroplasty. So when I look at my train track, what I like to do in the beginning is I like to educate patients on the disease process, give them ideas of how to self-manage, some ideas about things maybe to change around the house, hand railings, trying to put more things on the first floor of their house, either home exercise, some type of exercise program. It could be home exercises, it could be formal physical therapy. A lot of that is patient preference. And then some type of medication that's in the strong evidence group, which would be an NSAID or acetaminophen. And the little arrow is just to remind me that some people really can't tolerate NSAIDs. Weight loss if they're overweight, and then I'll often offer a brace or a cane. If that fails and we move down the track, as we move down the track, then if we were doing home exercise, maybe that's when we add formal PT. Maybe that's when I'll offer a corticosteroid injection. I have a lot of people who are asking for corticosteroid injections at the first visit. I'm happy to do that for them after we discuss the risk, benefits, and potential complications, and they understand what we're using it for. If they did not accept the brace or a cane the first time, maybe this is a time to bring that up again. If all that fails and they're continuing to have issues, maybe that's when we start to offer the HA injection, the PRP, potentially even referral for denervation, especially if they're not a good surgical candidate. And I only had room to put 4 steps. Again, you can divide this out into a greater number of steps or depots, if you will, along the train track. And finally, surgical consultation if all else is failing. So this is just an idea of potential progression for you. So to recap, knee osteoarthritis is extremely common. Numbers are increasing. We don't really know the true incidence, but it's going to continue to go up as our population ages and overweight continues to be an issue. Remember that the goals of treatment are quite simple. Keep their pain down, keep their function up, and try to keep them away from needing surgery. And there are a lot of non-surgical options that are available, but in a lot of cases, we don't have the evidence to really support the use of some of the things that we do on a fairly regular basis. And so you have to remain educated. You have to keep up to date on the literature. You have to come up with your plan of attack, but also be flexible because patients come in with ideas and they come in with ideas that are going to be helpful. They'll be honest with you. Sometimes they'll say, look, I appreciate that, but I'm not going to do it. And you need to be able to adjust on the fly. Something that's interesting that we found out here, we actually did a study on people with rotator cuff issues and their willingness to, or their attendance at physical therapy with rotator cuff problems. And we found that if you gave them a corticosteroid injection for their rotator cuff disease at the time of their visit that you ordered PT, they were a lot less likely to go to PT. Why is that? Well, because the corticosteroid works and it makes their pain less. And they feel, well, why should I go to PT? My shoulder doesn't hurt anymore. And I think if we did the same study in knee osteoarthritis, we'd find the same things. Because a lot of times we get patients back for their follow-ups and their knee pain is back. We said, well, did you go to PT? No, I didn't go to PT. Well, why didn't you go to PT? Well, I felt great. A week after I saw you, my knee wasn't hurting anymore. Well, the injection worked, but the injection doesn't keep you well. It just helps you get well faster. It makes you feel well faster, but it's the other things that you do that will keep you well longer. And it's something that they need to remember. So just to get back to a couple more CAQ questions, Melody, if I have enough time to run through a couple more, because these are off the actual CAQ, and hopefully from the talk, you'll be able to answer these questions. A 53-year-old patient with a history of chronic bilateral knee pain, who is a competitive runner and golfer, comes to you with worsening of his left knee pain since his last run about 4 weeks ago. His left knee pain has not improved much with almost 2 weeks of treatment with oral NSAIDs and physical therapy ordered by his PCP. His past medical history is only positive for bilateral knee OA. He has normal range of motion, but has pain with Murray's testing with deep knee flexion. He brings a copy of his left knee MRI, which is obtained by his PCP, because you know you're not ordering the MRI necessarily early on in these patients, which shows Kellgren-Lawrence 3 OA changes and a degenerative tear of the medial meniscus, which again would not be particularly surprising. What would you tell this patient? You recommend surgery to them because the knee pain with McMurray testing, that just blocked my ability to see my foil here. you would recommend continued non-surgical treatment. I'm sorry. Andy, can you take that down for a second? Because I can't see my there. Thank you. You recommend more conservative management if he tells you that the knee's locking. You recommend more conservative management because it's a degenerative meniscus tear in someone with higher grade arthritis change, or you recommend surgery because he's failed conservative management at this point. So now you can put up the survey and go ahead and everybody can vote on A, B, C, or D. Well, I'll just tell you. There we go. Look at this. You guys paid attention. It's great. Fantastic. So if we actually look at these, if we look at these more closely, McMurray testing with deep knee flexion, that's usually not going to be in an area where it's causing problems in a day-to-day kind of situation. And so that's not a reason to do surgery because of the McMurray test itself. And again, with Kellgren-Lawrence 3 changes, it could be from the arthritis that you're getting that change. If he's locking, that's a reason why you may start leaning more towards surgery because of the mechanical symptoms. The degenerative meniscus tear in someone with advanced arthritis is really the way to go. And this person's only had 2 weeks of treatment. They've not really tried a whole lot, quite honestly. And that makes D not appropriate because they've hardly failed conservative management. They're just getting started with conservative management. How about a 56-year-old female runner with knee pain who presents to the office? Progressive pain over the past 5 years with no history of trauma. Physical exam reveals crepitus, and on an X-ray, the office shows X-ray in the office shows medial joint line narrowing with an osteophyte. So again, level 3 change. What can you tell her about her osteoarthritis based on recent evidence? That running is strongly associated with future diagnosis of knee OA. Running has been shown to lessen the chance of surgery due to knee OA. There's a strong correlation between symptoms and imaging, or physical activity has not been shown to be beneficial for patients with OA. And again, these are questions straight from the CAQ.
We'll leave the poll open about another 10 seconds.
Perfect. I'm not going to vote. I know the answer. I wrote the question. Beautiful. You guys are all so smart. I love it. So again, running is not associated with future knee OA, and we know that physical activity is beneficial. I also try to drive home that you can't really know how somebody's going to feel based on what the image looks like. I look at X-rays sometimes and it hurts me to look at the X-ray, but they say they're getting along pretty well. And just as running is not necessarily correlated with the development of OA, it has been shown to reduce the likely need for surgery in the future. So your answer in this situation again is B. So I hope you found this helpful tonight. I really appreciate your time. This is Detroit. Best picture I've got of Detroit. It's where I grew up. It's Motown, but in a month, I'm actually moving to another Motown. I'm moving to Oregon Town, West Virginia, to join West Virginia University and the folks out there. And so I'm not putting up my contact information because I don't know what my email address is going to be when I get there. I don't know what my phone number is going to be. But if you go to the AMSSM website and log in and go to the Find a Doc, as soon as I get there, I'll update everything and you can feel free to contact me, not just about this lecture, but about anything in general. I think one of the nice things about being an AMSSM member is it's a very family-oriented type of organization. I have found it's my home organization. It's where I feel most comfortable. And when I need somebody in sports medicine to answer a question or to do a sanity check or just to scream at with regards to something that's really bothering me, and the people will lend an ear and listen and help. And I'm happy to do that for you as well. So again, thank you for your time tonight. I really appreciate it. And I hope you found this helpful.
Thank you, Dr. Moeller, for sharing that. That was fantastic. And if you guys didn't notice, I think he has the best speaking voice of somebody who isn't paid for the radio commentary. I think we got lucky that he went into sports medicine because we just make him go on stage and speak so that everybody can hear his authoritative but yet comforting tones.
Well, thank you. I do have a face for radio though, so that's helpful.
Also, those visuals that you shared for the treatment algorithms were really helpful. I'm going to want to go back and maybe take some pictures. I think the visual is really helpful for teaching residents and fellows, but also for patients. Also, the other visual, that X-ray of the autofusion of the knee was insane.
Yeah, pretty cool, huh? It's very rare. And in fact, that was one of our fellows had shared that with me. It's the only one I've seen in 30 years, and it wasn't even my patient. So I'm not getting to the place to unshare my screen here. I'm not finding that. I apologize. So you're still seeing, I think, my screen.
Let's see. Let me do mine, and then I can exit out of mine.
Perfect.
Okay. So we are at time. So I'm going to suggest that if it's late for you and you had budgeted an hour, now is a good time. Dr. Moeller was kind enough to give us some excellent CAQ examples. There are some questions in the chat that I think are great, especially for real life just applications. So for those of you who are still on, they were sort of asking mostly about some of the recommendations, but injections. Somebody asked about the NSAID that you use intraarticularly, and somebody else was asking about Serapin for pain relief versus a steroid. If you have any opinions on that, Dr. Moeller.
On the second part, I really don't have any experience with that. With regards to the NSAID, I typically will use 30 milligrams of ketorolac, and have found that to be quite useful. I have patients who, after the explanation of the potential not advanced, but the potential for increasing the degeneration process that's going on inside the knee with the anti-inflammatory or with the corticosteroid, and that an anti-inflammatory like ketorolac may cause less chondrotoxicity. A lot of my patients will opt to use that instead. And I'm happy to do that for them, but ketorolac 30 is what I generally will use in that situation.
Do you combine that with a cane or?
Yeah, typically I'll do 1 cc of lidocaine, 1 cc of bupivacaine, and the 30 of ketorolac. You know, when you're doing injections, there's not a lot of great science that says this is the mix to use. You know, and when you look at different steroids, you know, some are water soluble, some are not water soluble, but a CC is a CC is a CC in a lot of cases, and it's nice that the drug companies kind of set it up that way for us. And whether you know, I have my fellows, some of them will use 4 cc's of 1% lidocaine and a cc of triamcinolone, for example. How much of the anesthetic you use doesn't really matter to me that much, because it's going to wear off, you know, but by the end of the day, regardless, you have enough room in the knee to put a large volume in there, as long as we're not adding pressure to the knee and potentially adding pain for them, which is interesting because I always find that the pressure component of the injection is worse for my patients than the poke. They complain less about getting stuck with the needle and more about when you're pushing the medicine in. So again, if I'm putting a high volume in there, I don't want to add to that pressure feeling and that discomfort. So I tend to use lower volumes. But yeah, with a ketorolac or with a corticosteroid, I do use lidocaine and bupivacaine.
Somebody else, the other question that came up was just about guidelines, the OARSI guidelines versus the AAOS recommendations, and how they, somebody mentioned that there was a conditional recommendation for hyaluronic acid injections, which of course contraindicated the AAOS guidelines. Do you have any thoughts or opinions on that?
Again, you know, you can, it's like looking at statistics, right? You can manipulate statistics to fit what you want it to show in a lot of cases. I am not convinced enough that hyaluronic acid should be on the against use situation that I'm not using it. As I've mentioned several times during this talk, even though it shows up in that side of the equation, I still use it with great frequency. I don't like using it on the bone on bone patients. I always shake my head and you know, because they're coming back a lot of times in a month or two, and they're asking then for a corticosteroid injection, and it's like, well, why are we going, you know, and then they come back at the 6-month mark for their next set of hyaluronic acid, and it just, I think one of my jobs, and I hope one of our jobs, is to not only look at the evidence and practice medicine considering the evidence, not necessarily always following it, but considering it, but also trying to figure out ways to keep the cost of healthcare down. And it's why I don't order a lot of MRIs on patients, especially over the age of 50 with grade 2 or grade 3 arthritis changes. And it's why I don't like doing hyaluronic acid injections on people with grade 4 change. But as I said, I'm not convinced that it's should be in the taboo, don't ever do it side of the equation. So I still use it and do it. So again, I'm just showing you one set of guidelines. As you can see, it took me a long time to get through this tonight. When I did it for myself, I got through a lot faster. But this afternoon, but again, you can look at individual randomized controlled trials and come to the conclusion that it's the greatest thing since sliced bread and use it all the time. It's just that, again, we have a lot of bodies of evidence, a large body of evidence that when you try to take it all into consideration, it does start to temper those extremes of yes, we should use it, or no, we shouldn't.
Yeah, I think what you mentioned earlier in your talk was keeping function in mind. And I think that's something that non-operative sports medicine physicians do excellently, is take all of that data and also then figure out a way to use that expertise with the patient that's sitting in front of them. Because that patient's body did not read the textbook and did not read the studies. And so you do have to use your years and decades of expertise to try to guide them.
I agree 100%. Again, you read what you can, you gain experience from seeing people, and then with your patients, you make the best choices that you possibly can to help them in the way they need to be helped. And I always tell my patients, because I get asked all the time, and you will too, well, when should I get this replaced? Should I get this replaced? And the answer is, you tell me, because your knee will tell you, and then you tell me, and then I help you move in that way. If you have pain and I can't help you get that pain to a reasonable spot for you to be happy, or you have poor function and I can't get your function level up to a spot where you're happy, neither of those situations is acceptable to me as your physician. And so you have to tell me, am I helping you where you need to be helped? Am I getting your pain level down enough? Am I getting your functional level up enough? And it's not, am I making you pain-free necessarily? It's not, am I making you a marathon runner where you weren't before? Is it, do I have you to an acceptable level for you? And if that's the case, you don't ever have to go under a surgical intervention at all. And again, the patient is driving this ship, right? We're helping them navigate. And that's something you need to remember. And like Melody said, you've got to use everything at your disposal, from your interpretation of the literature to your personal experiences, to the experiences of the people around you who have helped train you and are working with you side by side, to make those best decisions with your patients. You're not making them for them, you're making them with them.
Yeah, well, that is a great, I think, end line for this lecture. So maybe we can stop the recording. And if anybody had specific questions or wanted to chat with Jim, we'll stop the recording and you can come off your mute and ask your questions face to face.